this week on the BackTable podcast.
Beyond the youth, and Lingling discussed this briefly before, was if there's somebody who I need a response, it had the highest response rate of any of the first-line trials that we discussed. If I need a response where I think the response could be meaningful and actually impact something that we're going to do forward. If we're trying to get a response so that they'll tear or will become easier or something along those lines, those are the patients, regardless of age. And so it focuses on the response, how robust the patient is, and some other parts of it that would be considerations as well to picking ipilimumab.
Welcome to BackTable HCC Weekend. We're going to start our next episode about more of a medical oncology approach to taking care of patients with HCC. I'm John Mizrahi. I'm a medical oncologist specializing in GI cancers at Ochsner MD Anderson Cancer Center in New Orleans, Louisiana. And I'm joined here by two esteemed colleagues. Dr. Lockhart, why don't you introduce yourself for me?
Yeah, thanks for the invitation. I'm Craig Lockhart. I'm a medical oncologist, longtime medical oncologist I'm at the Medical University of South Carolina in Charleston. I've been doing GI cancers for 25 years, and again, happy to be here.
Thanks. Dr. Du?
I'm Lingling Du. I'm a GI medical oncologist at Ochsner MD Anderson Cancer Center in New Orleans.
Great. And I think y'all two know one another a long time ago, huh?
Very long time.
We go back.
So Lingling trained at WashU under Dr. Lockhart and always said good things. So good to have you come down here, be a full circle reunion event here for us. So
I appreciate you all for inviting me.
So let's start with where we're at in first-line therapy. That's what our first conversation is going to focus on today. And we know that the real kind of watershed moment in HCC management was the introduction of immune checkpoint inhibitors, right? So the IMbrave 150 trial really kind of shook the landscape. So Lingling, why don't you just walk me through where we're at in terms of some of our options and how that study kind of paved the way for what we're doing now?
Well, I would say, interesting, Craig and I were just talking about this. So in May 2020, the IMbrave 150 study was published in New England Journal of Medicine, and that showed that frontline atezolizumab compared to frontline sorafenib improved over survival. And that was the first immunotherapy regimen in the frontline setting approved in the history of HCC. And then, so we have been using atezolizumab a lot ever since then. And then in 2020, the HIMALAYA study was presented at GI ASCO and showed that frontline the STRAT regimen, tremelimumab, durvalumab, improved over survival compared to sorafenib. So that was the second one that was approved.
So I remember when atezo-bev came out, that was a huge deal, right? Because we were using sorafenib and then lenvatinib some too, right? But that was the real breakthrough moment. So I think the practice changed pretty much immediately of everyone moving to atezo-bev. Craig, you were like already establishing your career at that point. So, I mean, what was that like for you going from where you used to practice HCC to that?
So, many of us who see GI patients regularly saw this coming. It was absolutely a watershed. But, going back to 2015, actually, when CheckMate 040 was presented as an oral presentation at ASCO, I think many of us were like, wow, this is better than we thought. We didn't know how patients with hepatitis B and hepatitis C were going to fare on this, as well as, just patients with HCC in general. And so I think people were fairly, blown away by just the results of CheckMate 040, just especially in the dose finding and then in the expansion cohort. And so it was one of those things where, okay, this is coming. And IMbrave 150 was sort of the manifestation of that. Okay, finally it's here. Now we can actually treat these patients the way that we think that they should be treated without having to scramble to try to get the immunotherapy otherwise. But absolutely, it did change the way that we were taking care of these patients. And it was one of those things where there was immediate adoption. Sometimes when things change, they have the stragglers, people who want to keep doing things with sorafenib or lenvatinib, whatever. But it was immediate and complete turnover as far as the way we're treating these patients.
That actually just reminds me that Craig and I was just talking about it. We actually, after the ASCO presentation of the CheckMate 040 in 2015, we have been using nivolumab. However,
in the frontline setting?
No, you can't, because that's a second line and beyond study. So you can't really use it in the frontline setting. Usually it would be like, still at that time, why is it so great? Because the only other thing we have is sorafenib.
Right.
So, but I would say after people progress on sorafenib, or people are not eligible for sorafenib, I have patients who look at sorafenib and I was like, okay, I'm not going to take this. Then we actually treat them with nivolumab at that time.
There was a short leash for sorafenib at that time. I mean, if the person even came in looking any kind of way
Right.
different, you're pulling the trigger and moving them over to nivolumab
Right.
because the results were that impressive from CheckMate.
So you mentioned atezobev and durvatremi, and then there's now a third player on
Ipi-Nivo.
the scene. So, and y'all want to just walk me through what that third player is, ipi-Nivo, and a little bit of the data and how that fits in as well.
Yeah, I think that's a very interesting data. AP3-Nivo1, that was from the CheckMate non-DW study. Again, very impressive result compared to frontline physician choice of TKI, which is actually better because you're not just comparing to sorafenib, which a lot of us are not using anymore. Actually, on that trial, I think 85% of patients on the control arm, they were using lenvatinib first line. And then compared to first line TKI, AP3-Nivo1 prolonged people's overall survival, and the response rate is actually the highest amongst all frontline regimen that we have.
Right. So we were seeing about a 2-year median overall survival with that combination, but also the control arm was 20 months as well, which, goes to show that I think we've gotten better in our treatment of HCC, but also is reflective of the fact that you weren't mandated to use sorafenib. You could use what we think is a more active TKI in that lenvatinib as well.
Yeah, as well as the second line. Second line therapies had improved at the time, and so that's going to increase your overall survival in general. I mean, the fact that we've been seeing, sort of, what was it, 24 months, I believe, and
24 months.
the fact that we've been seeing 24 months overall survival in HCC is something that, none of us would have seen, 10 years ago. It's just been tremendous.
Right.
Right. And we're seeing some tails of the curve too, right? So, I think probably the most data has been published with STRIDE, but
Right.
also with ipi-Nivo looking at 3-year,
Long-term.
4-year survivals.
Right.
Even I think with STRIDE, they've up to 6 years
6-year
now.
survival data.
So just talking about patients who are living that long is unusual
Right.
historically for HCC.
Yeah, I think for HIMALAYA, it's like frontline STRIDE data, 5-year over survival rate was 19%,
Yeah.
and then with 6 years, 17%. That was very impressive. We're
It's very-
talking about almost 1 out of every 5 patients after diagnosis of advanced stage, right? In the past, their median over survival, when we only had TKI, is definitely less than a year. And right now, 1 out of every 5 patients would be alive at 5 years, 6 years.
Now, it's, again, bringing the whole historical perspective in here. HCC wasn't one of those diseases that people thought much about when they were thinking about phase 1 clinical trials. It wasn't.
Right.
It wasn't an area of active research. You'd like it to be, but the patients were doing so poorly that it was not an easy patient population to study. That has absolutely changed. Where if you have 36% of these patients alive at 3 years, now you have to think about, and it's going to be further conversation. Think about second line therapies, and okay, now we have something that works. How do we make that a little bit better? So it's absolutely changed the way that we think about taking care of patients with hepatocellular cancers. And again, 24-month survival is tremendous.
And then I think the other very important part is, like, right now we definitely have more and more long-term survivors, right? And these patients, why do they have HCC? Because they have a cirrhotic liver, like a bad liver to begin with, right? And their already cirrhotic sick liver have to, in the past, probably only need to last them for like 10 months at most, right? And they can shut down. But right now, some of patients live for years. Their liver actually do need to preserve their function for years. Like, how do we make sure that we're preserving the liver function for years?
And I think that's increasingly important data that we're getting from these long follow-up from these trials is what does the liver function look like over time? I think when I explain it to patients, I'm sure you guys have your similar spiel. I say, we're fighting a war on 2 fronts. One war we have drugs, we have treatments,
Right.
we have ammunition for, and the other one we don't, right? Like we don't have a way to fix your liver.
Exactly.
We can do things that try to prevent it from getting worse, but if their liver's not going to continue to function well, then that could be the cause of their ultimate, expiration over time. So we'll come back a little bit to the nuances and patient selection, but I want to also comment on at least a couple studies that didn't pan out in the first line setting that got a lot of hype. So, and primarily the overarching theme around those was a combination of TKI and immune checkpoint inhibitor. So any thoughts on, those studies in particular, or where that's evolved in terms of whether that's still worth looking at or that journey's kind of gone and come and gone.
I think the LIP-002 study, the lenvatinib plus pembro versus frontline lenvatinib, that was actually, if you look at the overall survival data on the pembro and lenvatinib arm, it was pretty good. But the problem is the lenvatinib arm, the control arm, really outperformed itself.
Overperformed,
Right.
yeah. And the other was the Cosmic study, Cosmic 312, which was cabo plus atezo. And also with that one, I think PFS was improved, but not overall survival. So, I think, obviously we want to continue to improve upon our frontline options, but perhaps TKI plus IO might not be the way we're going to do that, at least with the data that we have. So going into the weeds a little bit about patient selection, because I think that's really what matters. We have, I think we'll all agree right now, we have 3 good regimens that we can use in the front line. Some nuance here, right? So with atezo-bev, we know that EGD is really mandatory for these patients within 6 months of how it was done in the trial within enrollment. So ruling out gastroesophageal varices that need to be treated because of the potential bleeding risks with bevacizumab. You look at with STRIDE, where you're only giving that CTLA one time. And then you're looking at the ipi-Nivo, which is you're giving more of the ipi and also at higher doses. So there are a lot of considerations that you may think about besides just looking at the numbers in terms of patient selection. And that's the ultimate question. When you have a patient in front of you, what kind of contraindications, relative, absolute, are you looking at? And if you don't have any, how are you making that decision of what's going to be your go-to frontline regimen? I don't know, Craig, you have any thoughts there?
Usually looking at, again, how long has the disease been present, especially the cirrhosis, how long has that been present? If patients have been cirrhotic for a long time and have had good follow-up, almost all of them have had an EGD at this point to tell us what's going on in the esophagus. So with those patients, they pretty much have the full menu open to them, because if they've had an upper endoscopy and there's no varices, or the varices are there, they've been banded, you pretty much have the full menu. Where the menu starts to get truncated is when somebody has not had an endoscopy, or again, cirrhosis hasn't been as long standing. If somebody has not had an endoscopy, depending on the health system that you're in, and getting endoscopy can be easy or hard. If I refer to one of my community colleagues, I can get an endoscopy tomorrow. If within the university setting, it can be a little bit longer. So some of that does impact, my selection. Some patients with cirrhosis will already have proteinuria, and again, that's one of the things that you need to consider, especially with the
or if they have diabetes for a long time, then
correct. That's one of the things you have to consider with the bevacizumab. And then some people with hypertension, that's sort of a little bit on the borderline. Again, you consider that as well. So if I have any concerns about the esophagus, or have any concerns about hypertension, or proteinuria has been previously seen with them, and again, there's some research that goes into the patient's background there, then I'm pretty much going to go with the STRIDE regimen in general. I'd say the first regimen was the atezo-bevacizumab, and so I'm very, very comfortable with that. So that tends to be the default. I try not to just run to that. I try to take all the different patient factors into consideration before making a decision. For ipi-Nivo, again, a little bit newer, although I again have more experience using that in other settings than in this setting, although the doses are a little bit different. I do have some concerns about the toxicity associated with that to a certain degree, and so I would say that's probably using that one the least as far as those 3 go, just because of the potential risk of toxicities. And, I feel like recently I've had a lot of people who, for whatever reason, have rheumatoid arthritis or something else that I'm having to get worried about. And so
or back Crohn's disease or something.
Yes, I haven't had a chance to utilize that one quite as much. I have, but I haven't had a chance to use that one quite as much since its approval.
So I'm going to ask you a couple quick questions. So one is, if you do have a patient with RA, are you doing for non-immunotherapy based, or you're just more worried about adding on CTLA-4?
I'm a little bit more worried about adding on CTLA-4. It depends. I can't say this is hugely scientific, but if somebody has a rheumatologist that is all over them, is on their case and co-managing with me, I'm a little bit more relaxed about doing, tremelimumab with those. I'm probably going to avoid, longer term CTLA treatment, and probably more towards the STRIDE regimen in that case. But if they have a rheumatologist who's actively engaged with them, I feel a little bit more comfortable and, give them a heads up that this is coming. I do feel a little bit better about that.
And I also feel that depends on how bad the rheumatoid arthritis is, right? I have patients, the rheumatoid arthritis is just a little bit pain or something. I also have patients, the hands are already like disformed. So
Yeah.
I don't feel comfortable to hit them hard with immunotherapy.
I also find that it's important on, not in these specific examples, but, patients might have a chart history of a lot of these things that aren't really, I've seen patients who have a chart history of IBD, and you really do digging and you're like, I don't really think you have IBD or RA. And it's like, no, that's just osteoarthritis. And then someone threw a label on it. At some point, it gets carried forward. So sometimes it does require a little bit of extra digging because you don't want to withhold a potentially, a very impactful treatment for someone if you are making the decision of using ICI versus not using ICI generally. So I haven't had in a couple of cases we've actually changed their diagnosis based, not me on my own, but, sending them out to a referral to GI or rheumatology and them being like, yeah, I think you're right. Actually, they don't truly have that diagnosis.
Absolutely. That's where the rheumatologist engagement comes in. If
Right.
they're there, it's probably real,
Yeah. If you have a patient who gets an EGD and they get their varices banded, are you then comfortable saying, okay, now we can proceed with bevacizumab? I mean, this is one nuance that, isn't really addressed in the trial because they just, excluded those patients. So what would be your comfort level of, a patient being banded using bev? Do you wait a certain amount of time? And have you run into that in your practice, Lingling?
So if the EGD show that it's esophageal varices and they treated it, I actually do use atezolizumab. But of course, for these patients, we survey them with EGD, monitor with EGD very closely. Sometimes I do EGD every 3 months just to make sure that there's no new esophageal varices popping up.
Yeah. Do you ever use platelet as a threshold to not give bev? Like, let's say their platelets are chronically below 70. Is that someone you're more concerned about using bevacizumab? Does that not really factor into it?
I think if it's chronically below 50, I will worry about if they start bleeding, they're not able to stop the bleeding.
I agree. That's a reasonable number. Usually I'm sort of in the 75 kind of range. But, to go back to your question about the banding duration, now if there's banding, and I don't need to even think about that, I can go to something else. I can do the stride regimen if necessary in that case. But I would feel comfortable, similar to what Lingling is saying, probably 2 weeks is probably good enough where I feel comfortable with that.
Okay, so Lingling, I'm going to give you a case. You have a patient in front of you, Hep C, cirrhosis. Their LFTs are totally normal. We'll call them Child-Pugh, and they have portal vein tumor thrombus and a left adrenal met. And they show up in your clinic. They had an EGD 3 months ago with their very astute and on top of things hepatologist. What are you reaching for in that patient?
Does he have esophageal varices?
So correct, I left that detail out. So that EGD showed no esophageal varices.
Oh, so that's great. I have a few of these patients, although these are not the majority of patients because these patients have great liver function, which does not happen a lot. But for these patients, actually, for all the 3 regimen, I will go over every single one of them. And then I will discuss the side effect profile, the response rate, the survival data, and everything with the patient. And we'll have a talk, and the patient will choose. A lot of our patients, interestingly, even with young patients, when young patients, we're actually more tend to recommend ipilimumab if they're good candidates, right? They're young, they can probably handle it. But a few of my patients feel that they don't want to be sick at all. I definitely have a lot of patients feel that quality of life is the most important thing for them. They just don't want to suffer, right? If it's a limited amount of time. So a lot of them actually will pick atezolizumab in that setting.
Craig, do you have a different approach, or would you say your line of thinking, since you train Lingling after all, is pretty similar?
She's been away from the mothership for a long time. I would probably say my assessment would probably present all 3 as well. I haven't done. I would say, and I mentioned this earlier, of the Ipi-Nivo has been the one I've utilized the least, just because again, potential tolerability with those kind of things. I think the other 2 are very, very well tolerated. And so with somebody with portal vein thrombosis, I don't know, I might lean away from an anti-angiogenic drug, but just because of the potential risk of bleeding or thrombosis or something along those lines, I might lead away from that one. But so it would probably be 60-40, probably towards stride. In a situation like that.
All right, I'm going to change it up slightly.
Okay.
All right, now this patient has Child-Pugh B7. Everything else the same. Their EGD looked okay, but they have their belly's up a little bit and their albumin's down a little bit. Is that changing your approach? It sounds like, Craig, you're kind of already leaning towards STRIDE. My guess, I'm not going to put words in your mouth, that probably pushes you even more towards STRIDE. Maybe not. Or are you not using this at all because technically the approval came in just A, or Lingling? Does that change your approach? Just the only shift being B7.
So B7, basically, I would not even talk about ipilimumab with them
Okay.
because, like you just have to be great in order to handle that. I would talk about atezolizumab and STRIDE. I do feel that both of them in B7 disease they could probably tolerate both. So I think probably will still be atezolizumab.
So similar conversation.
Mhm.
Doesn't change a lot.
Right.
Craig?
Well, B7, there are different B7s, and we talked a little
Right.
bit about there are different B7s that, again, when you start seeing changes pushing someone towards a B7, do you think it's a cirrhosis? Do you think it's a tumor? What do you think is the, what is it, do you think is the inciting factor
Right.
pushing them towards a B7? We've all seen the people that, how is that a 7? How does that person a 7? Are the ones that, they look great and the numbers just happen to
Right.
add up to 7. But I would agree with Lingling that I think the, I Am Brave 150 versus STRIDE, I don't think I have a preference one way or another with those. I do have more experience with atezolizumab in those situations because it's been around longer. And so I would probably do that just because, again, just more experience with that. But I agree. I would probably stay away from the Nivo in those patients.
One thing I do in practice, and I agree with everything you guys have just said, is I also take the chronicity of that Child-Pugh status into account, right? So I feel like the patient you can watch over the last 3 to 6 months, their liver function deteriorating is already kind of on that downhill slope, is a very different patient than someone whose bilirubin has been 2.5 for 3 years. So that patient, even if one's a B7 and the other one's maybe even a B9, even though B9's really pushing it. I mean, I'm actually more comfortable that more chronically ill liver than someone who's kind of on that downslope. Would y'all agree with that? Or am I just wild?
No, I think that's definitely very legit, but I do feel that that's muddy water because most of the time we don't know, say for the post patient, like chronically B7 versus most recent 3 months is rapidly deteriorating. Is it the underlying cirrhosis that is rapidly deteriorating, or is it actually because of cancer that's rapidly growing that it just progressively get worse? Then if it's the latter, should you try to give them more, not potent, like the ones that with high response rate, trying to get a response? I just feel that, again, in clinical practice, to be honest with you, whenever their liver function is rapidly getting worse, but we still have a chance that we can start them on something, we always wanted to start them on something that hopefully we can reverse this deterioration, right? Sometimes it works, but sometimes it doesn't work.
We'll have time to get a little bit more later in terms of combination of immunotherapy and local regional therapy. Do either of you have a preferred regimen that you would use? Like, let's say you are going to use a combination of radioembolization, Y90, and immunotherapy, or whether it's TACE at your practice, or dare I say histotripsy. What would be, is there a preferred regimen for that kind of thing? Or are you saying, I'm going to use what I'm going to use anyway and just time it differently? I know I have my own biases, but I don't know what your practice may be, Craig.
For me, I would use STRIDE in those patients because there's going to be a lot of messing around with vasculature. We've been, we talk to the interventional radiologists all the time, and TACE or TARE or whatever new technology that they are going to all goes through the vasculature. And anytime somebody's going to be having repeated procedures over and over again and those kinds of things, I tend to avoid something that could potentially put the patient at risk for bleeding. And so again, it would probably be into STRIDE regimen in a situation like that if I know that I'm going to be combining my therapy with some kind of liver-directed therapy.
Okay. Lingling, do you have any different
We
practice?
do a lot of combinations, right? We combine a lot of immunotherapy. Even like before 2020, we were combining nivolumab with Y90. And at Ochsner, they actually, majority of cases, they use Y90. They use radioembolization rather than TACE. I think it depends. If it's like we know that it's one treatment, like one Y90 to take care of everything, then I think doesn't really matter, right? If I need to hold BEV, I only need to hold it once. But if we know that they're going to do multiple treatments, like serial treatments, stage treatments, then I would definitely prefer using stride. Initially, I had the same feeling, right? When I give people BEV and they need to have somebody's poking them, either with a scalpel or with a needle, I worry about like, are you going to bleed? Is the wound going to, even a small wound, is going to heal? Then about a few years ago, I gave my patient BEV and then we held it, and then they were taking the patient for local regional therapy. And then about like even 6 weeks later, like we held it for a long time. And then the interventional radiology, like they security checked me right away. Like we couldn't do this because BEV was so powerful that the blood was not flowing into the HCC at all. So like whatever they deliver, it's not going to
Totally
be exactly.
revascularized the
Exactly.
supply. So yeah, I mean, I kind of agree with both of you. I've adopted stride as my go-to kind of partner immune checkpoint combination with local regional therapy if we know we're going to do it, right? I mean, if you're starting systemic and they have a tremendous response and then you kind of want to consolidate them, that's different. But I agree. Is there a patient, you mentioned a young patient, is there a patient that you would say you are that perfect candidate for ipi-nivo? Because I know we kind of danced around that our uptake doesn't seem to be super high from the CheckMate 90W regimen. But I mean, outside of maybe a young patient who you think could potentially handle those extra toxicities, or you want them to get the longest survival benefit, or however you want to word it, is that kind of the paradigm of someone you would mostly consider?
Beyond the youth, I and Lingling discussed this briefly before, was if there's somebody who I need a response, it had the highest response rate of any of the first-line trials that we discussed. If I need a response where I think the response could be meaningful and actually impact something that we're going to do forward. If we're trying to get a response so that they'll tear or will become easier or something along those lines, those are the patients, regardless of age. And so it focuses on the response, how robust the patient is, and some other parts that would be considerations as well to picking ipi-nivo.
I would say yes. And then the other thing is good performance status. They are able to run to the bathroom if they develop colitis. It cannot take them 2 minutes to go to the bathroom.
Not during clinic.
Not during clinic. And then good performance status and good liver function.
Yeah, I think that all makes sense. Okay, that's going to close out our initial chapter here of discussing first-line therapies. Anything else y'all want to add before we close out here? Or that seemed pretty comprehensive.
It was a great time together.
I think, as I said, I said at the top, HCC was one of those things that nobody wanted to. It was a cancer everybody avoided, right? As a GI oncologist, I want to see colorectal. I don't, that kind of thing or whatever. But HCC is one of the ones you avoided, and this has absolutely changed it. Where I think I'm seeing more patients who are potentially first-line eligible. When they used to talk about Child-Pugh, I was like, those patients don't exist. But now they're there. Now you're seeing them. They're getting referred sooner and those kinds of things. So, it's a good time to be, again, a patient suffering with this thing. And it's a good time to be, somebody who's able to provide those kind of therapies for them.
And then I think the other very fascinating part for me when it comes to this job is, remember, for all the other type of GI cancer, when we talk to patients about the first visit, we talk about goals of care, prognosis, and everything, right? For almost all the other, like we have a prognosis for the patient, right? We have data. But when it comes down to HCC, a lot of times I'm like, I don't know what your prognosis is. I don't know how long you have, because like we definitely see patients who are long-term survivors, like had a complete response or partial response, and years later still doing great.
Okay.
I have a few patients after a few years of treatment, like we decided to go on a treatment break and they're still doing good.
Yeah, I mean, that's the beauty of immune checkpoint inhibitors, is that we just don't have with chemo for the vast majority of our patients and other GI cancers. So, agree.
The tail is real.
The tail is real. All right. Well, thank you both. I enjoyed this conversation, and we'll be back for more conversations about HCC management from the medical oncology perspective.
All right. Thank you.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon, Aaron Bowles, Gabe Bagrizio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.